Well, here we are back for part 2 of chapter 21. We're going to dig a little deeper into abdominal and GI emergencies. We'll start this off talking about some specific abdominal and GI emergencies, and then we'll dig a little more into the assessment and management of some specific conditions. So in order for us to have a really good understanding, or it's really important for us to have a really good understanding of many conditions that can affect those patients that are having an abdominal issue. In some systems, paramedics can actually help online medical control decide where the patient should go. And that could be an ER, maybe a clinic, or even just to their primary care provider. So the more that you understand about a patient's particular condition, the better you're going to be able to educate and help guide that patient towards the best or most healthy choice for them. For example, patients with cholecystitis or gallstones or gallbladder issues should pay close attention to their diet, and they need to watch what they eat. Eating fatty foods can trigger painful attacks. So avoiding them can help reduce signs and symptoms of those flare-ups. Educating the patients about these types of things can be helpful if you have a good understanding of what's going on. And also pointing them in the right direction for receiving care. Most gallbladder attacks are not going to get a whole lot of emergency room care, and they're better off going to their primary care provider if the conditions aren't too severe. We typically associate hypovolemia with bleeding, but it can easily be caused by dehydration due to vomiting or diarrhea. So we need to keep that in mind, especially when we're, looking at GI related issues. When this happens, the body tries to compensate by shifting water from the cells to the interstitial space and then into the vascular space to try to maintain that blood volume. Eventually, though, the body reaches its limit and it can no longer move enough fluid to keep up with everything that it's losing. During this process, electrolyte levels get out of whack as well, especially sodium and potassium. These levels may either increase or decrease depending on the severity and the cause of the dehydration, which when that happens, it begins to affect other parts of the body and we start to see other effects of that, maybe whether they're cardiac effects or cellular effects in other ways. Electrolyte imbalances due to diarrhea can affect several different things, and this table kind of shows what those things can do. So low sodium is going to cause swelling of the cells, and hypokalemia is going to be, it's going to cause more stimulation for that particular nerve to respond to that. So if it's a cardiac cell, it's going to take more of an impulse in order to get that cell to respond. If it's hyperkalemia, it's going to make the cells a lot more sensitive to electrical impulses. So getting somebody that's dehydrated, their issue extends beyond the hypovolemia, and we have to look more closely at the electrolyte imbalances that are associated with that as well. But realize that this can, of course, hypovolemia, as I mentioned, can also be caused by hemorrhage, so we don't need to completely overlook that. And of course, causes of GI bleeding, we're very familiar with, could be trauma, but it also could be an erosion of the protective lining of the inside of the intestine. Could be chemical damage to tissues, or a dilation of blood vessels, which can rupture and cause severe bleeding. The bleeding may be slow and gradual over days, or it could be sudden and massive all at once. So look for those signs of shock. That's going to include anxiety or restlessness, pale, cool, clammy skin, maybe a fast heart rate, narrowing pulse pressures, and an increased respiratory rate. Remember that a drop in blood pressure is actually a late sign and is an indication of significant volume loss. So we don't want to wait until the blood pressure starts to give us a clue that they're actually losing blood. We want to be aware of that and be proactive. So let's talk about some of the assessment and management of particularly of GI bleeding. Remember, the bleeding part of GI bleeding is a symptom and it's not the disease itself. So we're just seeing a side effect or an effect of that particular disease that they may have that's causing this bleeding. Whenever we have bleeding in the GI tract, it almost always points to some other underlying condition. Obviously, a stab to the belly or a gunshot wound to the belly, it's pretty obvious where the bleeding's probably coming from. But aside from trauma, there's something in there causing that. Typically with an upper GI bleed, we're going to see what's called melena, or dark, tarry, really black stools in there, oftentimes really foul smelling. That's an indication of an upper GI bleed. Lower GI bleeds will typically show up as a bright red stool, and it's what we call that hematochezia. So it's a bright red stool. It indicates that blood has not been digested yet. It hasn't went through the whole digestive tract. So this table is going to show us some of the causes of that GI bleeding. If it's the esophagus, it could be from an inflammation or varices, maybe even a tear, or dilated veins. This is where we're going to see those dark, tarry, black stools from the blood loss that's been, it's digested. Same with the stomach bleeding there, we're going to see that. And even the small intestines, we're going to see those dark, tarry stools. So we're going to really look for, if it's dark, tarry stools, we're going to look for anything small intestine up. And then if it's large intestines, we're going to think, if it's bright red, hematochezia type of blood, then we're going to look for large intestines down. That's typically where that blood comes from when it's bright red, because it hasn't been digested. So presentations of GI bleeding vary depending on the condition, and of course each one has its own kind of pattern of progression. Knowing the onset of symptoms is really, really helpful in kind of making a better determination of what's going on. And of course we do that by getting a detailed medical history. Ask them what medications that they're taking, because some may actually cause more irritation of the GI tract. Check if they're on any meds that affect blood clotting, such as blood thinners or things such as that. That may cause some bleeding in the GI tract. Ask how long the symptoms have been going on, so you can make a determination of maybe how much blood loss maybe they're suffering from. We want to make sure we start fluid resuscitation early on these patients. Get a good IV line and administer 1,000 mils of fluids. Options are going to include, saline, Normasol, isolate, plasma light. Of course, lactated ringers are pretty common. In most cases, it's going to be a normal saline or lactated ringers that we're going to administer to them. Esophageal varices is basically they're swollen blood vessels in the esophagus or stomach that's caused by an increased pressure on the nearby vessels. It's typically associated with issues with the liver that cause the blood to back up. This happens because there's some kind of damage in the liver and the blood's not flowing through the liver as it should, and it begins to back up. It backs up into the portal circulation, leading to portal vein hypertension. Hepatitis C is one of the most common causes of this underlying diseases, but it could be any really thing that affects the liver. So any type of hepatic disorder or disease can lead to an esophageal varices. It's important to realize that while an esophageal varices is caused by a backing up of the blood, there's something else that's causing that at the liver level in order for that to happen. It's a progressive thing, doesn't typically happen overnight. There's usually some signs leading up to it, but it can be very dramatic when they do start bleeding significantly. These patients typically begin to show early signs of liver disease, such as fatigue, weight loss, maybe even a jaundice color. They'll have some losses in appetite, maybe a swollen abdomen and some itchy skin. They may even experience a little bit of abdominal pain and some nausea and vomiting kind of going along with this. The big thing is we're going to start to see that jaundice color in the skin and the eyes that gives us an indication that there's something going on with their liver. And you combine this with throwing up blood or bright red blood that they're throwing up is kind of an indication that they've got something, maybe a varices going on. When they rupture, the patients will experience sudden discomfort or pain in their throat, severe swelling, vomiting of bright red blood, their blood pressure will drop, and they're going to begin to develop clear signs of shock. There is a chance that the bleeding might be a little less severe, and you might see some vomiting of blood, and there maybe even be some black stools too, because some of that blood actually gets digested through the tract. So not all of them are going to have the severe bleeding. The ones that do it's going to be a very dramatic thing, and their blood pressure is going to drop quickly, and they're going to require immediate treatment. The H&H or hemoglobin hematocrit levels will drop due to the blood loss. Liver enzymes are typically elevated in these patients because it's indicating some sort of an underlying liver damage that's going on with them. Our care for them is going to be mainly following those typical pre-hospital emergency management principles. We're going to carefully look at the amount of blood that they've lost and be prepared to replace some of that volume, and to maybe even suction and manage the airway if things start to go really south. If their LOC drops, you may need to secure an airway, with an endotracheal tube or something that's going to provide a very secure airway and prevent aspiration. Always make sure with these patients that you're wearing full PPE, and watch the airway, the ABCs, as you're going through this. They do have a tendency to vomit large amounts of blood, and it can even be projectile vomiting. The next one we're going to talk about is the Mallory-Weiss syndrome. It's when a tear forms at the junction of the esophagus and the stomach, so right where those two meet. This can lead to severe bleeding, and in some cases can be life-threatening. It's usually caused by forceful or prolonged vomiting. So it's not so much a disease process as it's a side effect of something else going on. The tear is usually limited to the mucosal lining, so it doesn't go all the way through the esophageal wall most of the time. This is more common in men between the ages of 40 and 50. It's more common for it to happen in that age group. With Borhave syndrome, the esophagus tears longitudinally or down the length of it, and the tear may go all the way through the wall of the esophagus, creating a hole or leaving an opening. Blood, air, food can leak into the esophageal opening and enter the mediastinum and into the chest cavity. This condition is usually seen in men after a large meal, especially one involving alcohol. Not really sure why alcohol plays a role, but it does play a role. If not treated, within 2 days, the mortality rate is 90%. I can't imagine going 2 days with a big hole in your esophagus. Mallory-Weiss syndrome, of course, that tear at the esophageal junction, we typically see them vomiting blood. So it's mainly upper GI bleeding. With the Borhave syndrome, the little bit of difference in that is they typically show the symptoms of chest pain, some shock, and subcutaneous emphysema. You would think with the Borhave syndrome that you would see a lot more of the blood and vomiting and that kind of thing, but Mallory-Weiss typically has that, and the Borhave will start to see some chest pain. Now, is it critical that we are able to distinguish between the two because the signs are very subtle? The results of it are pretty similar, but the signs are a little bit different. The signs can be kind of subtle and they can overlap. It's not necessarily critical that we're able to, say definitively which one of the two that it is, but having an idea of what's going on. It can easily, we don't really know, it could easily be an esophageal varices as well that's causing the blood loss. So it's hard to tell. The thing is, the assessment and treatment's going to be the same. For both of these, they are both linked to vomiting. Some form of vomiting that causes this tear to happen. In women, the vomiting may be tied to pregnancy, while in men, it's often related to alcohol consumption that's caused some damage to the lining and the esophagus. With Mallory-Weiss syndrome, that's the one, remember, it's going to present with bleeding, which is going to be really severe. In the really most severe cases, expect to find them showing signs of shock, and they're going to have some epigastric abdominal pain and vomiting blood. They may even have a history of some black tarry stools if this has been going on for a little bit longer, and maybe it was a mild tear that the tear got worse. Clearly, if there's a mild tear in blood, because of vomiting and blood goes into the stomach and irritates the stomach further, they're probably going to vomit more, which could lead to a larger tear. So, Borhave is, of course, going to present with vomiting as well, but they're going to have more of the upper chest pain and not so much the epigastric. The pain is going to be worse with swallowing, which is it's not typically what you find in esophageal varices either. So there may be little or no bleeding, but the complications that really can arise from this is, of course, septicemia, pneumomediastinum, which is where air gets trapped in the mediastinum or the center chest cavity, mediastinus or inflammation. May even have some subcutaneous emphysema where there's some air trapped under the skin. So watch for these, especially if this is something that's happened hours prior to them calling for help. We might see fever. We may even see full-blown sepsis. Sometimes the sepsis symptoms are so severe we kind of gloss over maybe the other symptoms of the Borhave syndrome. So it can be easily not noticed. They may even have some difficulty breathing or chest pain. As I mentioned before, it's important. The main thing is that we manage them correctly. Not knowing exactly what syndrome is going on is not as important as managing them correctly. So with Mallory-Weiss, we want to make sure that we assess and monitor the extent of blood loss. And the blood loss could actually be worsened with dehydration involved in that as well, that was caused by the vomiting that resulted in the tear. So we're going to need to make sure that we're managing the replacement of their fluid volume well. Borhave syndrome should focus on managing the risk of sepsis. So the two of these where the road kind of Y's off, one, you want to make sure that we manage the blood loss. The other is we want to try to mitigate or negate the risk of sepsis, because that's going to be the biggest risk for the Borhave syndrome patients. Treat the chest pain as if it's myocardial infarction until it can be ruled out. You may not have any choice there. And of course, contact medical control with managing these patients. These patients may be a little tricky, so it's why it's important. It's not something that's real commonly seen in the field. However, you may get a call for this. And if you've got a patient for either one of these syndromes, if you've got a patient that's been vomiting, complaining about severe vomiting, and then begins to have these epigastric pains or chest pains, maybe with some blood or, some other symptoms, starting to run a fever, we should start to maybe suspect that there may be something more severe going on, and they're going to need transport. Peptic ulcer disease, not typically something we get a call for, but sometimes people don't understand what's going on with their bodies, and they'll call us for these, stomach pains and discomforts that they're having, thinking something more serious is going on. But basically with peptic ulcer disease, it's going to cause an erosion of the stomach and the duodenum's protective lining, and it gets painful. It's the acid in the stomach in these areas begin to damage the organ itself. It's been kind of eroded away. This is not something that develops quickly. It's usually weeks, months, maybe even years that these begin to develop. More and more, they're kind of tying the cause of these to the H. pylori bacteria. I think that and gastritis itself is too. Gastritis usually results from an imbalance between stomach acid and the protective layers of the stomach lining. It's considered a pre-ulcerative state where the stomach is inflamed but no erosions have quite yet occurred. So we've got this inflammation going on in the stomach that may be a prelude to an ulcer developing. As I mentioned before, typically these are both of these conditions are tied back to the Helicobacter pylori infection in the stomach. It's a very robust bacteria that kind of hangs in there. It's hard to get rid of. The stomach acid won't get rid of that bacteria in and of itself, and it's going to require treatment to get rid of it. Erosive gastritis can actually be caused by maybe the overuse of NSAIDs, maybe severe burns or some kind of trauma. Lots of alcohol consumption and even smoking can lead to it. There's also something called Zollinger-Ellison syndrome, where tumors in the pancreas and duodenum lead to an increased production of gastric acids that can ultimately result in one of these two conditions happening to them. So it could be related to the pancreas kind of acting up and doing something as well. Typically with either one of these conditions, we see the patients reporting a burning or gnawing pain in the epigastrium that subsides sometimes after eating, but then it'll return 2 or 3 hours later. It's not uncommon to see nausea and vomiting, gas production or belching. Heartburn is very common with this, as is fatigue and anemia at times as well, because the absorption rate starts to get messed with, wind up with maybe some pernicious anemia. And then we might even see them with some pain that wakens them from their sleep. Usually the ulcers with peptic ulcer disease, it's usually the ulcer may be considered perforated if the erosion has penetrated through the wall of the stomach or the duodenum. This can lead to a sudden increase in pain and it becomes more profuse. And then of course the likelihood of infection begins to increase with a perforation, because contents of those the stomach or duodenum can then be leaked out into the interior portions of the body. Management, of course, is going to be to take care of any blood loss or manage any blood loss, and hypertension that may be showing up. Monitor for the orthostatic vital signs, so do that tilt test on them that we talked about a little bit earlier, and evaluate their fluid needs. And this will help you kind of figure out where you're going to transport them to once you kind of have a little better picture of what's going on. Be aware that they can have sudden vomiting and with a change in position. So you might want to use a stair chair instead of having them lay back or stand, those kinds of things. Of course, sepsis is going to be a concern if they've got a perforated ulcer, and we may need to give fluids if they've got a significant blood loss. Gastritis management is generally going to be, just our general supportive care, but we may need to consider some antiemetics with either one of these peptic ulcers or gastritis. Sometimes those provide a significant amount of relief and stave off the possibility of vomiting. So gastroesophageal reflux occurs when the lower esophageal sphincter, that valve that separates the esophagus and the stomach, opens and allows stomach acid to move up the esophagus instead of staying put where it belongs. It's also referred to as acid reflux disease. Commonly causes heartburn. Many people complain of heartburn when they have GERD, and they associate the two, kind of like acid reflux. So GERD, acid reflux, heartburn, kind of mixed together in there. Common risk factors that we see, of course, is smoking. Smoking's a big risk factor to that. Obesity, pregnancy. Oftentimes pregnant women suffer from some GERD when they get into the later weeks of their pregnancy. Lots of fatty or fried foods does it. Alcohol intake, and of course citrus fruits will kind of exacerbate the condition as well, make things a lot worse. A hiatal hernia is a little bit different, and it occurs when part of the stomach pushes through the diaphragm into the upper part of the chest cavity. If that part of the stomach becomes trapped above the diaphragm, it forms a small little pocket there, and the upper door is the lower esophageal sphincter, and the lower door opens into the diaphragm. So basically you get this little pocket or a little pouch between the pylorial sphincter and the diaphragm, and food can get trapped in there. Of course, there'll be some symptoms that are going to be similar to GERD, but most hiatal hernias are asymptomatic. The condition is often caused by an increased amount of intra-abdominal pressures, and it's more common in older women than men, probably because of those pregnancy years. Symptoms may include some heartburn. GERD symptoms typically include heartburn, which is worse when changing position or laying flat. We typically see those symptoms get a lot worse at bedtime. Coughing or even difficulty swallowing may be common as well. There is a chance of some bleeding, so they may have some hematemesis or melena, but it's not super common, but it is very possible. Hiatal hernias, on the other hand, typically only cause symptoms when food and acid cannot be efficiently cleared from the pocket that's created. Retained acid can lead to erosion of the stomach lining and maybe even bleeding, and of course some pain. Management of these, for both of these conditions, is going to be supportive. Medical treatment is actually going to aim to reduce the acidity of the stomach, which can include antacids, proton pump inhibitors, and H2 blockers. There's a lot more treatment out there for it these days than there once was. Surgical repair may actually be required in some cases. Be mindful that the symptoms of a myocardial infarction can sometimes be mistaken for GERD and vice versa, and that the excessive use of antacids can actually lead to metabolic acidosis or alkalosis. It can lead to metabolic alkalosis if they overuse antacids. This was pretty common when Tums and Rolaids were the only two options out there, and they were just chewing these alkaloid tablets like crazy trying to get the acid down, and over time they would reduce the acid in their entire body. All right, another fun topic here is hemorrhoids. They're typically caused by swelling and inflammation of the vascular cushion surrounding the rectum, which can lead to some lower GI bleeding. They're usually not a big threat, but they can be. They can be triggered by conditions that either increase pressure or cause an irritation of the rectum. Increased pressure can be due to, of course, pregnancy. We see a lot of postpartum women, suffering from these. Anytime there's straining during bowel movements can create these, or chronic constipation in patients. Irritation can be caused by diarrhea and other kinds of things. Hemorrhoids are classified in two types, internal and external. Of course, they kind of goes without saying which ones are which, but the internal ones are typically painless, but they can prolapse and wind up being external. The external ones are typically the more painful ones, and that's where we get the swelling and the clot formation and those kinds of things. Signs and symptoms would include, that bright red stools or the hematochezia. Itching and discomfort is often pretty common with that in the rectal area. There may be a small mass or lump around the rectum, often indicative of an external hemorrhoid. As you can imagine, pre-hospital treatment is going to mainly be supportive. If the patient has any bleeding disorders or takes blood thinners, this can kind of change things. It can change the dynamic a bit if there's a lot of bleeding. Do orthostatic vital sign check to see if everything is kind of holding their own, if they're still hemodynamically stable. In the hospital, they might just need some topical creams, or they may need surgery. To give advice on how to prevent these, you would encourage them to have fiber-rich diets and regular physical activity to keep things moving and reduce that pressure that builds up. Anal fissures, on the other hand, are different, and they're basically small tears in the mucosal lining of the anus, commonly caused by the passage of large, hard stools. This is actually something that is pretty common. Can also result from conditions like Crohn's disease, HIV, trauma, and anorectal cancer, anal rectal cancer, not colorectal, sorry. Patients often report sharp pain during bowel movements, and the pain may linger for minutes or even hours afterwards. So to avoid the pain, some of them hold off going, which then leads to the stools becoming harder and things blocking up even more, which is going to cause more pain. And this creates a vicious cycle of this repetition and keeps these fissures from healing. Management's mainly going to focus on keeping the patient comfortable. We may need to put a dressing down there or a cushion to help reduce some of the discomfort. Don't pack anything into the fissure. And of course, most fissures, they say, will heal on their own, so surgery is typically not needed for these. Esophagitis is simply an inflammation of the esophagus. It can be caused by an infection or stomach acid backing up in a reflux situation. Regardless of the cause, it leads to irritation and swelling. Patients might complain of indigestion, such as, or dyspepsia, or even a choking sensation. It can look a lot like GERD, which makes it a tricky diagnosis. Pain is usually felt on the upper belly and maybe even the lower chest. It often gets worse when the patient bends over or tries to lay flat. Common symptoms include a bitter acid taste in the mouth, maybe trouble swallowing or painful swallowing, or they feel like food might be stuck in their throat. Physical symptoms might not show much, but the symptoms are actually going to be the main clue. So our main thing that we're going to do, like many of these, is we're going to focus on providing general supportive care. Chest pain on these can be tricky, so we're always going to have to treat these like a possible heart attack until we find evidence to prove otherwise. Tracheoesophageal fistulas is an abnormal opening between the esophagus and the trachea. Tracheoesophageal fistulas can be something that you're born with. It can be congenital, or it can develop later on in life. These can be caused by maybe cancer or trauma, or maybe a medical procedure that has taken place. There could be tumors involved in this, a tumor of the esophagus or trachea that breaches that wall of both of them, maybe even penetrating wounds. A tracheoesophageal fistula basically lets food from the esophagus enter the trachea and then travel into the lungs. The most serious complications of this, of course, are pneumonia, which can lead to sepsis, which then can lead to death. Preventative measures like tracheotomy can reduce the risk, but it won't completely eliminate it. If the fistula is due to cancer, they might be coughing a lot, and the fistula could could cause a persistent cough. They could have a fever, which is a sign of infection or inflammation. Aspiration is really the big one that we're worried about. It means that food or liquid that was supposed to go to the stomach is now going to the lungs, which can cause some serious problems like pneumonia and maybe even lead to sepsis. They also might have a lot of gas, which can cause bloating and discomfort. If the patient has a tracheostomy, you need to take note that a decreased level of consciousness is a very serious sign. Again, fever is going to indicate infection. And as mentioned earlier, sepsis is the thing that we're going to worry about the most, because it's that life-threatening condition where the body has an extreme response to an infection. Coughing is still a symptom and could be related to irritation or aspiration, especially if you're looking for signs that suggest a problem with the normal pathways of breathing and swallowing. Coughing, fever, and aspiration are common red flags, but other symptoms give clues about the potential cause and severity of the situation. Top priority is making sure that they can breathe and that we address any signs of sepsis and we begin treating that quickly. Evaluate elevate the patient's head and help manage the secretions that they may be having. If the patient is septic, give IV fluids and vasopressors. Surgery will likely be needed to repair the fistula that they've got. Esophageal stricture and stenosis is when the passage of the esophagus becomes abnormally narrow. The esophagus can narrow due to a few reasons, like inflammation, maybe a tumor, could be an infection. Acid reflux that causes inflammation may result in a narrowing or a stenosis. As the esophagus narrows, swallowing becomes harder, and this usually happens in the lower part of the esophagus, and it's actually more common in men. Most patients will have a history of frequent choking episodes and symptoms like excessive secretions, the sensation of choking, maybe difficulty swallowing or even painful swallowing. They may have some breathing difficulties or have difficulty speaking. And they may have a difficult time managing some of the oral secretions that they have because they have a difficult time swallowing them. Main priority is to ensure that we keep that airway clear. The patient may be at risk for aspiration or obstruction, so keep an eye out for that. But most importantly, make sure that the airway is stable. If it is stable, avoid any kind of aggressive obstruction removal techniques. If they can't breathe, treat it like it's an airway obstruction and manage it accordingly, trying to get that airway clear so that they can breathe. Consider giving glucagon for esophageal obstruction. Now, this may not be a protocol, something you typically see in your protocols, but this can help relax the esophagus and allow for the obstruction to pass. Its effectiveness for strictures is limited, so contact medical control before using it for this purpose, but it is possible. So if you contact medical control and they recommend that you give glucagon, it's because it does have the ability to kind of relax the esophagus. Have the patient stay sitting upright and be prepared to assist with managing some of those oral secretions. If that obstruction clears before you arrive, advise the patient to go on to the emergency room for further evaluation. So if that clears out before you get to them at the scene, and they seem to be doing okay, it's a good idea to recommend that they go ahead and go on to the hospital. Okay, so part 2 is in the books. We'll be back in just a little bit with part 3.